Today on Patient Presentations, we are looking at cellulitis, the presentation, pathophysiology, investigations and management. Firstly, what is cellulitis? Cellulitis is a bacterial infection of the deeper dermis and or subcutaneous fat. Here we can see a diagram of the skin layers, including the epidermis, dermis and subcutaneous fat, with the bacteria penetrating the deeper dermis and subcutaneous tissue in cellulitis. Erysipelas is a more superficial form of cellulitis, affecting the upper dermis and possibly the local lymphatics. Now onto the pathogenesis of cellulitis. This requires two main steps. First, there needs to be a breakdown in the skin barrier. This allows the bacteria entry into the skin. This may not always be obvious, however, it is important to check for any open wounds, lacerations, tinea, ulcerations, insect bites, etc. Now, many of us will get cuts or scrapes and do not develop an infection. This brings us to the second key requirement. The bacteria needs to overwhelm the existing host defense. This occurs when the individual's immune system is unable to mount a sufficient response. This is where risk factors for cellulitis are relevant, including type 2 diabetes, age, obesity, and previous episodes of cellulitis. Presentation. Cellulitis typically presents as erythema, warmth, swelling, tenderness, and possibly reduced movement in the affected area. Now, these characteristics may sound familiar because they are present in a variety of different medical conditions. They are the cardinal signs of inflammation and are not specific to cellulitis. It is important to remember that inflammation does not always equal infection. This is often forgotten in clinical practice, and cellulitis is often misdiagnosed. It is important to rule out differential diagnoses that can also present with inflammation. Examples include deep vein thrombosis, compartment syndrome, or alternative infections such as necrotizing fasciitis. In cellulitis, the area of erythema is typically less distinct, with the more superficial erysipelas being well demarcated. In addition to the characteristic inflammation, individuals with cellulitis tend to be systemically unwell, with fevers commonly preceding the skin changes, as well as nausea, vomiting, reduced appetite, and fatigue. During the physical examination, it is also important to look for any evidence of fluctuance to indicate presence of an abscess. An abscess is a collection of pus that may be present in addition to the cellulitis. It is important to determine if an abscess is present, as treatment options will differ if this is the case. Investigations. For simple soft tissue infections in patients seen in the primary care setting, investigations may be unnecessary, and oral antibiotics may be commenced based on the clinical diagnosis of cellulitis. Possible investigations, however, include bloods, which will likely show elevated inflammatory markers, including white cell count and CRP. It is also a good idea to do electrolytes, urea, and creatinine to assess renal function as well as liver function tests, as this is important to know when determining best antibiotic therapy. Blood cultures may also be done in systemically unwell individuals to assess for bacteremia. A swab or wound MCS may be taken if there is any discharge from the wound. The most common bacteria causing cellulitis include beta hemolytic strep and Staphylococcus aureus. Most staph in cellulitis is termed MSSA or methicillin susceptible Staph aureus, and will respond to a multitude of antibiotics. Some staph, however, will be termed MRSA or methicillin-resistant Staphylococcus aureus and may require alternative antibiotic therapy. Less common bacteria may, however, be present in unusual circumstances such as in animal bites, water exposure, chronic diabetic wounds, etc. Bedside ultrasound can be performed if there is clinical evidence of abscess, or formal ultrasound if there are concerns for a deeper collection. Alternative imaging, such as a Doppler ultrasound, could be performed if there is concern for DVT as a differential. Management. Simple soft tissue infections may be managed in the community with oral antibiotics if there are no systemic features, for example with a 5-day course of oral cefalexin. However, if systemic features are present such as fevers, vomiting, lethargy, initial therapy with IV antibiotics is most appropriate. Flucloxacillin or cefazolin are examples of commonly used initial IV antibiotics for cellulitis. It is important to note that flucloxacillin can cause LFT derangement, and cefazolin needs to be renally adjusted in patients with renal impairment. If a wound swab has been taken, further antibiotic therapy can be guided post-return of sensitivities. For individuals with methicillin-resistant Staph aureus, an alternative antibiotic vancomycin may be required. It is important to note that not every wound MCS that returns positive for MRSA necessarily requires treatment with vancomycin if a good clinical response is already seen with an alternative antibiotic such as cefazolin. Some individuals are colonized with MRSA, having this bug as part of their usual skin microbiome without causing infection. Healthcare workers, for example, are frequent colonizers of MRSA. It is also important to consider the source of infection to see if any further atypical antibiotic cover, for example with oral doxycycline, is indicated. This is important with patients that have had that water exposure or animal bites, etc. Also note that if an abscess is present, IV antibiotics are unlikely to be fully effective. You can think of an abscess as a collection of pus. This collection is unable to be fully penetrated by antibiotics and will likely need incision and drainage in addition to intravenous antibiotic therapy. That concludes this summary of cellulitis. We covered the patient presenting with cellulitis, pathophysiology, investigations, and management. I hope this was helpful, and please leave a comment below if there are any questions or further video topics you would like to see.